we'll go through anthrax. So anthrax is commonly also known as wool sorter's disease and malignant pustules, and is caused by Bacillus anthracis. Bacillus anthracis is a large gram-positive spore-forming bacillus, and it occurs naturally in soil and is a pathogen of herbivores such as cattle, sheep, and goats. Human infections are due to direct or indirect contact with animals or animal byproducts or animal products. So this slide here shows the anthrax cycle. First of all, the spores in the center, and they occur in the environment or soil, and it is ingested by the cattle or other animals while grazing, browsing, or maybe drinking or inhalation of spore-laden dust or contaminated animal feed. And then inside the animals, germination of the spores occur. The spores, they develop into vegetative forms and multiplication in the lymphatics and spleen, resulting into severe infection and even death of animals. And from the animals, infected animals, the vegetative forms are shed into hemorrhagic exudates from the nose, mouth, anus, spilled blood from dead animals. They all contaminate the soil again, and as soon as the soil is contaminated or the spore, it gets exposed to oxygen in the environment, it gets sporulation, and spores are formed from the vegetative forms. And these spores in the environment, they can be inhaled or ingested, or maybe make come contact with the cutaneous abrasions or anything like that in the humans while handling the animals, ill animals or animal carcasses or animal products, etc. And then it may manifest different types of infections in humans, like if it is by inhalation mode, respiratory system is affected. Gastrointestinal symptoms can be seen, gastrointestinal infection, or maybe cutaneous. The cutaneous one is the most common, and it may result into complications like meningoencephalitis. And this is what this slide shows. And let's talk about the epidemiology first. It is the worldwide disease of domesticated and wild animals, and may secondarily infect humans. It does not spread from humans to humans. WHO estimates that every year 2,000 to 20,000 human cases occur in the world, and the disease is more common in Middle East, Africa and Latin America. In Nepal, animal cases have been reported, but I tried to find out, but there were no case reports of human infections. So the virulence factors are antiphagocytic capsule. So we all know the capsule is made up of polypeptide capsule, in contrast to other organisms which contain polysaccharide capsule. And it also contains two exotoxins encoded by PXON plasmid, and they are edema toxin and lethal toxin. So edema toxin is made up of protective antigen and edema factor, while lethal toxin is made up of same protective antigen plus lethal factor. And edema toxin, it inhibits primarily phagocytosis, while lethal toxin, it decreases cytokine and chemokine expression, macrophage clearance, and increases the macrophage apoptosis. So we'll first discuss cutaneous anthrax. Here is a picture showing cutaneous anthrax. It's also called Hyde-Porter's disease, and more than 95% of anthrax cases are cutaneous anthrax. Mode of transmission is entry through abraded skin. Incubation period is 2 to 5 days, followed by fever and chills. Pruritic papules at the inoculum site, which develops into vesicles in 1 to 2 days. These vesicles then mature into ulcers, forming a characteristically black base. So in Greek, anthracis means coal, and this blackening of the ulcer is indicated by the name anthrax. And the mortality rate in untreated cases is 10 to 20%, while in case of cutaneous anthrax, if the cases are treated, they are rarely fatal. And reinfections are very rarely reported and are milder than the primary infection, and this implies that some degree of acquired immunity is there in case of cutaneous anthrax. And so here comes injectional anthrax. It is an uncommon form of cutaneous anthrax, It has been described in injectional drug abusers. For example, in history, there were cases of contaminated heroin abusers getting injectional anthrax, and the skin lesions are not typically cutaneous anthrax lesion types. Rather, they present with advanced localized soft tissue infection. So, inhalational or pulmonary anthrax is also called Wool-Sorter's disease, and the incubation period is 1 to 6 days. The first symptoms, they resemble flu-like symptoms, which later develop into high fever with declining pulmonary status, respiratory distress, dyspnea, marked diaphoresis, pleuritic chest pain, and confusion and syncope. And with or without therapy, this declining pulmonary status then can develop or may progress into late fulminant stage, and the mortality rate is very high. That is 92%, as high as 92% despite treatment. And another type of anthrax infection is gastrointestinal anthrax. Oropharyngeal or intestinal infections with Bacillus anthracis are indicative of gastrointestinal anthrax. It is quite common in grazing herbivores but uncommon in humans, acquired by eating undercooked or dried meat of infected animals, and the incubation period is 1 to 5 days, and the mortality rate is 40% without antibiotics. And then comes anthrax meningitis. It is an uncommon sequel of cutaneous anthrax but very frequent complication due to bacteremia in inhalational or GI anthrax disease. And severe headache, altered mental status, meningeal signs, and other neurological signs followed by any kind of anthrax infection can independently predict meningitis in this case. So laboratory diagnosis can be done with microscopy, in which the specimen that can be used as swab in case of cutaneous anthrax, sputum in case of pulmonary, and stool in case of intestinal anthrax, and blood can also be used. And gram staining will reveal gram-positive bacteria that are arranged in single or in short chains with square off or concave ends, just like shown in the picture. An area of spore is not swollen, and the spore staining can be done with malachite green. So green spores in pink to red cells would be seen in case of malachite green spore staining. And then culture is gold standard. The specimen can be swab, sputum or pleural fluid, stool, and blood. And blood agar medusa head colonies that are non-hemolytic and tenacious are grown. So immunohistological studies can be done using anticapsular fluorescent antibody, and serology can be done to detect anti-PA antibody of acute and convalescent sera. So molecular method includes PCR targeting for PAGA gene in plasmid PX01 and CAPB gene in plasmid PX02.